Dr. Denise Ejo, the CEO of Cornwall Cancer Foundation. I would like to welcome you to our Cornwall Cancer Foundation page. Our goal is to create an awareness of the challenges, support and guidance experienced in managing cancer care for sufferers, family, carers and friends. To engage with us, don't forget to subscribe to our channel, click our notification bell.
This comes up every second and fourth Wednesdays in every month, and this month is no exception. And of course, this is the second edition. The topic for this Wednesday is endometrial cancer, knowing your body, and of course, again, Cornwall Cancer Foundation will be speaking with a consultant obstetrician and gynecologist, Dr. Alexander Onyonyo from Jamaica, and she's already here to begin the conversation. I want to say a very big thank you again, Doctor. Welcome. Good to have you with us. Very interesting conversation you're taking on today. Good to see you.
Morning.
Good morning, Doctor. You look very cheerful today. Absolutely.
It's good to be cheerful.
Yeah. Over to you.
Thank you. Good morning, everyone, and thank you for joining us again as we talk about cancer and we create our awareness. Today in the house, we've got Dr. Alex Onyonyo, who is a consultant obstetrician and gynecologist. I'm not very good in all these words, and I always say it. Well, he's currently visiting Nigeria on a medical mission to Edo State under the auspice of the Association of Nigerian Physicians in America, in collaboration with the Edo State government. So, Dr. Alex, we want to thank you. We understand you're here with quite a few medical professionals doing orphan drugs, consultations, and all that. Thank you very much. We really appreciate that and the work you're doing for us in the space. So thank you for joining us on AIT this morning.
Good morning, and thank you for having me on the show this morning. Good morning to the viewers as well.
Okay, so today we're going to be talking about endometrial cancer. But for us to be able to start this conversation, there's quite a lot of things that are going on. So I want us to look at everything I'm going to give you some questions. I'm going to start from a point of where we are at as of today. Today, a lot of people know that I live with cancer, and one of the things that's come to bear with me of recent in the last 1 week, which was very heartbreaking, was the fact that I've been funded by my cancer treatment through cancer research globally, right? And it's very heartbreaking to see that the death rate in Nigeria is honestly looking very bad now. And we have a cancer fund that unfortunately cancer survivors and cancer patients in Nigeria do not have access to, which is a serious concern at this point. And although we're talking about endometrial cancer, is that correct?
Endometrial cancer, you're correct.
Okay, I got it. A lot of stakeholders need to be getting involved in this conversation. So endometrial cancer, apparently I understand, this usually happens with women over the age or in menopause. And it says I understand it cannot be prevented. I'm not sure. So I'm trying to throw questions. I'm trying to give you a background of where we are coming from this morning so that you can educate us, because that's what we need. So what is endometrial cancer and who is at risk of endometrial cancer?
Thank you very much. I'd like to make a disclaimer before we start that Denise and I are actually classmates from secondary school.
I knew I guess that's that. You just wanted to have a big, right?
Oh yes, I have to have one.
Yeah, I have to have one.
Thank you so much, Denise. And I've been with you on the journey for quite a bit, and I know exactly the passion that you bring to the topics that we cover. And the good thing about our environment in Jamaica is that, and in Nigeria, is that endometrial cancer, which is cancer that arises from the inner lining of the womb, so that's what it is. So the inner lining of the womb is actually called the endometrium. So women who have periods will bleed from the lining of the womb every single month. So that lining also grows, and as you know, cancer is really uncontrolled growth, and sometimes that lining starts to grow in an uncontrollable fashion. It's a very common cancer in the developed world. In the developing world, not so much. So in Nigeria, for example, endometrial cancer is not as common as cancer of the cervix. In the developed world, we have basically controlled cervical cancer because we have effective screening programs. So it's not as if it's less, it's just that there are programs in place to catch cervical cancer or catch changes in the cervix before it becomes cancerous. And that brings us to the problem of endometrial cancer. There are very few recognized screening methods for endometrial cancer. The good thing, however, is that endometrial cancer is, for want of a better word, a good cancer. So who gets endometrial cancer? Typically, women who go through menopause, and typically that is between the ages of 50 and 51. And 75% of patients with endometrial cancer will be above the age of 60. But there's a percentage of patients who are still having periods who might also have endometrial cancer. And what puts you at risk? Now, for example, in the United States, 2.8% of women can expect to have endometrial cancer in their lifetime. That's a lot of women. But that translates to about 70,000 women per year. And of those, about 11,000, which is about 1/5, may not make it through. So what makes endometrial cancer a good cancer? It is easily diagnosed because most of the patients have gone through menopause. So once you haven't had a period for 1 year, around the age of 50, 51, and you notice any kind of bleeding at all, no matter how much it is, no matter how little it is something that needs to be checked. So who is at risk? The patient at risk is typically in that age group, between the ages of 52 and 64, but typically around 60. Typically, it's a woman who is on the well-fed side, a woman who has had few or no children. Sometimes it's patients with diabetes and hypertension as well. We don't do a lot of hormone replacement therapy, but patients may be on hormone replacement that may put them at risk. So patients who take some medication like tamoxifen for breast cancer, since we're talking about cancer, might be at increased risk. And there are some conditions in families. There's an association between endometrial cancer, colon cancer, breast cancer, and ovarian cancer. So there's a little genetic component to that. That's a small percentage of cases. So that typically is the group that's at risk. But there's some things that can, reduce your risk. I can't come on TV and ask patients to go have children because you have to look after them. But if you have children, you're less likely to have endometrial cancer. If you use a contraceptive pill, you're less likely to have endometrial cancer. So anytime you have that effect where your lining doesn't shed that often, you are at risk of endometrial cancer. So patients who have menstrual irregularities, for example, because every woman produces the female hormone called estrogen, and it's there all the time. So if you're pregnant, you produce something called progesterone, which basically counters the estrogen, and that stabilizes your lining. So if you have too much of the estrogen for a long period of time, then the lining has a tendency to overgrow, and that's what causes the problem.
Okay. So we're starting very nicely.
Yes.
You've done some. You moved me very well, so that's good. So basically, with endometrial cancer, about 75% of us that can have it will survive it. So we've got between 30 to 25 to 30% that will survive it. Okay, we agree that cancer has its own, because there are other variables. Where I'm very clear now. Cancer has other variables that affect you and your ability to be able to do well. Okay, so now, what can we do to prevent getting the disease?
So that's a tough one. Because endometrial
let me rephrase.
Okay.
I know, but I don't want to put you on the box. Okay, go on then.
Yeah. So we have tried several things to try to, because the principles in cancer treatment really have to do with you trying to prevent it from happening, making a diagnosis as early as possible, and instituting treatment. The problem with endometrial cancer is there is no recognized approach to screening. So if you talk about breast cancer, you have mammograms and ultrasounds. If you talk about cervical cancer, you have pap smears and other things. But with endometrial cancer, there is no recognized screening method on a population-based basis. So if you have a family history of endometrial cancer, and you have some other conditions, for example, polyps in your colon, then there are ways to screen you to prevent you because there's an increased risk. But for a general population-based approach, there is no established way to screen for endometrial cancer. So that's the answer to the question.
Okay. Maybe I'll come back again. Okay, yes. Maybe I'll come back again from a different point. Okay, so how do we differentiate? Because how do we differentiate? Because now you've brought in the other two cancers that are linked to it. How do we differentiate between endometrial cancer and the cervical cancer and is it ovarian? Is that
ovarian, yes.
Yeah. Okay. How do we differentiate between the two? Yeah.
All right. So it's really quite simple. I think any bleeding that is abnormal, and this is why patients need to know what their regular menstrual pattern is. Any bleeding that's abnormal needs to be investigated. And that investigation will generally tell you whether it's likely to be cervical or something else. Now, the answer to cervical cancer is endometrial. So for women we're talking about women who are older, right? So these women are typically older. Now, any bleeding in a woman who stopped having periods requires evaluation. I think part of the challenge we face is access to care. So patients may have a little bit of bleeding, and culturally they may not say anything to anyone, and therefore it becomes a lingering problem. But if you actually have the bleeding investigated, you can easily differentiate between cervical cancer and endometrial cancer, because cervical cancer is something you can see in the majority of cases. So if you do not see cervical cancer on the examination and the cervix looks normal, it's likely to be coming from higher up beyond the cervix, which requires some kind of investigation, typically an ultrasound. Ovarian cancer is a slightly different kettle of fish because the ovary is a very small organ that's buried deep in the belly. So before you actually associate the problems you're having with the ovary, it's going to take a long time, which is why ovarian cancer is really, on the other spectrum, not a very good cancer to have, because by the time you find out, it typically will spread. So that's how the process really works.
Okay, so I'm trying to look at the triangle. I'm a visual learner, so I'm very, very clear. Yeah. I'm a visual learner. So I'm trying to look at the triangle now, and I'm seeing that the endometrial cancer stands in the middle. It is curable if it is caught. However, if it's not, well, every disease has those that will not make it on it. It's not just about cancer. However, 2 out of 3 have screening programs. That's the ovarian and what do you call it? Cervical, right? Cervical. We don't have it on the other one. Okay, I'm coming somewhere. I'm going somewhere. Don't worry. So in that case, how is okay? How many people? Let's not worry. Let's think about this. Many people worry about cancer. We know that, and is endometrial cancer? So you say it is curable if you catch it on time.
So right? The majority of cases, right? So I think the majority of women who have stopped having periods recognize that bleeding 1 year after you have periods, which is what typically is,
1 year
is abnormal. So if you've stopped having periods, say at age 51 and at 53, you notice a little bit of bleeding. It tends to be a small amount of bleeding. You would know that something's not right. I shouldn't be bleeding anymore. My periods have stopped.
It's very specific.
Yes, very specific. Which is the reason why this is a good cancer, because it shows you a sign very quickly. So remember that for a lot of cancers, your survival and your treatment depends on how far away the cancer has moved from where it started. So if you're still in the endometrium, which causes you to bleed, then it's easy to just remove that organ and you're essentially cured. That's why this cancer there's no something like a good cancer, but this is one of the better ones to have, certainly from a female point of view, because the treatment is simple and it is curative.
Okay, so we'll go to the next question. How is the treatment?
Yeah. So again, the treatment, yeah. So again, we just alluded to that fact. I think our greatest challenge is access to care, because on this mission, for example, I'm doing surgeries on patients with very, very large fibroids. And you ask yourself the question, how does it get to this point? But again, these are other issues that you raised, public health issues, funding for healthcare, and that kind of thing, and awareness, of course. So you do a great job with the awareness part. So the treatment is very easy. I mean, every gynecologist can do what is called a hysterectomy, which is to remove the uterus. So the majority of the cancers will show up early when the cancer is still confined to the womb itself. And a simple operation to remove that womb will cure the majority of patients. So you know about 5 year survival rate. That is the number of patients with a particular cancer who will be alive after 5 years. In the case of endometrial cancer, that is 80%. That's the best number for any female cancer.
I'm smiling here now. I'm smiling here.
That's the best number for any female cancer. Yeah, there's hope. Yeah. So the older your population gets, the greater the tendency. But I am not sure if cultural barriers prevent grandmothers and mothers from telling their children and bleeding. So that's why I suspect there might be some challenge with endometrial cancer.
Yeah, but that would. Go on.
Go ahead. Sorry.
No, go on.
I was just going to say that apart from surgery, there are other methods of treatment, but those are for advanced cases. The majority of patients can be cured by a very simple operation, and that's really what's recommended.
Yeah, but that's a very positive takeaway for a lot of women who are currently sitting there with maybe a bit of bleeding, and it's coming and going, and say, wow, if this is what it is, why don't I just get this sorted? And hopefully recognize that we're already over 50, so we shouldn't be sitting down thinking we're looking for the children, but rather find a way to live life. That would be something I'm trying to say. Yeah. Okay. So one major way of treating cancer is using radiotherapy, right?
Right.
But in most developing countries like Nigeria, where we have very bad access to medical, we're accepting that, right? And it's very expensive. Is this option useful? Is that okay? When we talk about the removing the hysterectomy, but then you also have those that are going to have gone past the hysterectomy level to the next step. What would their options be going forward for cancer treatment? If they've got past that and they've got the cancer, there's nothing you can do again.
So I just want to say that the hysterectomy is an essential part of the treatment. In fact, I'd like to rephrase that and say it's a crucial part of the treatment, because the operation itself helps to do several things. It helps to remove the uterus, but it also helps you to assess if there's any spread outside the uterus. So the surgery has to be done. It is only after you've done the surgery and subjected what you received to lab testing can you now say that, well, I need some more treatment. So the surgery serves as one, diagnosis and treatment. So the surgery helps you to define how widespread the condition is, because that's what determines what kind of other treatment you might need. So you have to have the surgery first. Once the surgery is done and we decide that this cancer has spread beyond the lining of the womb and possibly outside the womb itself, then you may need something else. So chemotherapy is available, that's using the medication, and also radiotherapy is available. for the treatment of this condition. You're right in saying when you have gone past, but there are some patients who are not good candidates for surgery because they have other kinds of conditions, whether it be heart disease, whatever else, that prevents them from having surgery. Then you can actually use medication to try to reduce the rate of spread of the condition, to give the patient a comfortable life and potential cure in endometrial cancer. Did that answer your question, I hope?
Yes, you did. You actually brought some things to bear because looking at the options, it's quite encouraging, first and foremost, to know that at least there is a good chance. But it's also a concern, and I'm not just looking at it from just our perspective, but I'm looking at it from this cancer awareness campaign, that the cost going forward, the cost of treatment should not be as high if we've already got 70% of the, we've taken the womb out, and then there's just tidy ups. But when now the tidy ups, we can't fund the tidy ups as cancer patients, then the whole journey becomes very, very heartbreaking from somebody who's going through the cancer, because you've gone a long way up your treatment plan, and then you get to a point and you can't go further. And that is not something you or I can solve, but that's something we have to bring to the forefront to say this is a concern, and the people who are in government who have to make those decisions need to hear that cancer patients are crying for little help because we can't access funds to get treatment. So it's like a cancer patient in Nigeria is now struggling to live. If you don't have money, it's like, do you have any hope anymore? And the government needs to come in and step in and say, look, because there is a fund. And so we're trying to say, let the fund be activated for all of us. Because I sit with the cancer, I'm still starting a new chemo in another 2 weeks. And it's very heartbreaking to have to sit down and have to be having this conversation at this point when there is the money, and the money is not accessible to the patients, especially when you're telling me about endometrial cancer that actually has a very good prognosis if things are done on time and move forward. You get where I'm coming from? So that is where I'm coming from. Okay, I'm going to ask you one question.
Okay, sure.
Oh, do you have something? Did you have a comment to add to that?
Yes, I had a comment to make. Whilst I do not speak on behalf of ANPA, which is the Association of Nigerian Physicians of the Americas, as we speak, the officials of ANPA are on their way to the airport here in Benin to Abuja to try to speak with the lawmakers to advocate for an increase in the budgetary allocation to health and for the improvement in healthcare services. ANPA is also hoping that the model that we have employed in this case, which is to bring the services to the people, those of us in the diaspora who have something to offer, we'll bring ourselves down here to help with capacity building. There's a lot of training that's going to go on in terms of things like helping mothers survive, helping babies survive, and of course the transfer of skills and knowledge. The experience has been an interesting one because there's certainly a lot of constraints, and one sees that. So we're advocating for an improvement and for a change, and we hope that some of this change will also spill over to cancer treatment.
Thank you, because you see, but that's what this is all about. It's not about one particular illness or whatever. It's more about how do we move forward to help a typical everyday Nigerian survive. Like I said, I am treated, I'm treated on cancer research funding. If it's not for cancer research, I couldn't pay my medical bills, and we have to be factual about that. So how many people who have little cancers that could be paid for and should have been paid for should be dying at this point? It's not necessary. It's like life is no longer valuable, and that is a sad reality. Okay, I'm going to ask you a question. Give me 2 things that should be done to improve the narrative. My fundamental drive is to help us improve our narrative. We need to help each other to get past this. Okay,
so the first thing I'm going to say, like everything that has to do with healthcare, right? Healthcare has to do with awareness, because access is possible if you're aware of what you're up against. So what you're doing is particularly commendable, because once you're aware of what might be a potential problem, then you might be able to address that problem. So education, healthcare education, which is what you're doing, certainly makes a huge difference. Now, the other issues of access to care are a little beyond me, but what you, in many societies, it's quite difficult for the average person to pay for cancer treatment in full. Very difficult.
Yes.
So where I live, for example, healthcare is free. So if you want an MRI, you want radiotherapy, it's all free. Of course, that comes to other issues like long waiting times and stuff. So we have to fund healthcare better, and we have to educate our patients. And I think if we do those two things, we should be able to make a dent in this, what I would call simply treated cancer that can be treated very easily. Any general hospital should be able to treat this. Care shouldn't be a problem in this kind of case.
You see, now you just broke my heart, because I like what you've just said. We shouldn't be having to have this conversation. But I'm sorry, in the last 1 week, I can count at least 7 people who have died of cancer for no reason. And it's not necessary. And that just broke my heart, because when you say it's easy, why are we dying? I sit on this chair. Why are we dying? We don't. It's like we've been rejected to society, and honestly, the government and lawmakers. I'm glad your team are here. Let them to go and talk, because we're all making noise now. Please come and save us and let us not have to die, because we don't have to die. It's not necessary, and it's unfair. And I think the society has to recognize that. But anyway, thank you very much, Dr. Alex. Thank you for joining us today. I'm not going to put you on any more high jump this. I'm
quite good with the high jump, but I want to say thank you for having the program and to commend you for the marvelous job that you're doing.
Thank you.
I think hope is there. There's hope once we continue on the path, and we hope that things will change in the near future.
Yeah.
Thank you for having us. Yeah.
Thank you. Just want to say, Common Cancer Foundation, we do host a monthly Zoom and a webinar. We're having the webinar actually in the next 1 month, with quite a few stakeholders from different parts, international and local and Africa, to come and talk about changing the narrative, and that we should be sharing that information over the next 1 week to get people to register online and get onto it. We've also got 2 CEOs of cancer foundations coming on to speak to us in the next one week. So let's see how that goes. No, next 2 weeks. I think it's the next 2 weeks we have them on, and we will be talking with them about the narratives, family, friends, and all the people that have to do with the cancer journey. So flyers on that one will also be out. You can now follow us on Common Cancer Foundation on our pages, websites, and all the social media platforms that we have.